All right. Hello, everyone. So we're going to get started. I hope you all are doing well this evening. So I just wanted to introduce myself. My name is Allison Haggerty. I'm a health promoter with our Chronic Disease and Injury Prevention division here at Public Health. So I just wanted to start with a little bit of a land acknowledgement before we get started. So I just wanted to go through this. So the land is, the Niagara region is situated on treaty land. This land is steeped in the rich history of the First Nations, such as the Haudenosaunee, the Haudenosaunee, and the Anishinaabe, including the Mississaugas of the Credit First Nation. There are many First Nations, Métis, and Inuit from across Turtle Island that live and work in Niagara today. The regional municipality of Niagara stands with all Indigenous peoples, past, present, in promoting the wise stewardship of the lands of which we live. So I just wanted to welcome you all to our Niagara Region Public Health rounds, focus on alcohol and health. So we just wanted to go through a little bit of a disclosure, if you just want to go to the next slide, before we get started. So we just wanted to acknowledge that this session is funded by Niagara Region Public Health. Our funding does come from the province of Ontario, which provides funding to public health research, programs, and resources that may be discussed today. Next slide. And all data, resources, and recommendations presented are based on current scientific literature and data. All right, so just a little bit of housekeeping to start off our session. For those of you who are attending online, I can't see you right now, but welcome. We just ask that if possible, if you can just change your Zoom name to your full name. That way we can just keep track of who is participating in the session this evening. And then we also welcome you to turn on your camera if you are able to do so. And then at the bottom hand left corner of your screen, that's where you'll be able to find how to do that. And then in the bottom middle of your screen, you will see participant buttons as well as a chat button. So that will come up on the right-hand side once you click on that. We have muted all participant lines just for the purpose of the session currently. However, the chat box is open for any questions, comments at all that you may have throughout the session this evening. And then for those of you who are attending in person, there is actually a speaker located in the desk on the desk in front of you. So you'll see that there's a little symbol on there. It kind of looks like a Wi-Fi symbol. If you end up pressing that, that'll turn on your microphone. That'll allow those of us in the room to hear your voice loud and clear, as well as those who are attending online as well. Just remember when you're done speaking, if you do so, just remember to turn that off. So next slide, I'll just get through our agenda quickly. So we do have Dr. Matt Greenway here as part of PCAL, the Primary Care Advisory and Liaison Group, just to do a little bit of a brief update about PCAL, as well as some recruitment for 2024. Next, Dr. Azim Khan, our Medical Officer of Health, will be doing a local context presentation speaking to local epidemiology related to alcohol use in Niagara. And then we have our keynote speaker, Dr. Peter Butt, who is the co-chair for the 2023 Canadian Guidance on Alcohol and Health. He'll be speaking to the clinical guidance and those clinical implications of our new Canadian Guidance on Alcohol and Health. All right, finally, we're going to wrap up with a little bit of this facilitated question and answer period. So again, if you have any questions, feel free, for those of you attending online, submit those in the chat, and then we'll have a bit of a discussion at the end for those in the room as well. All right, so without further ado, I'm going to welcome up Dr. Matt Greenway to speak about Primary Care Advisory and Liaison Group.
Thank you. Good evening. So my name is Matt Greenway. Moved here from Ireland in 2007. And I received a package in the mail yesterday, which was a 4-pack of Guinness Zero, so 0% alcohol Guinness, which is delicious, and I thought it was good timing for today's talk. So I did my family medicine residency here in 2010 with Dr. Dack, and I've worked as part of the Montebello Medical Group in St. Catharines since then. So before COVID, I did not have much of a reason to particularly engage, or if I did engage, it was voluntarily with public health. It was either over vaccines or STI reporting or reading Dr. Herdy's newsletter. And I think that during COVID, our interactions and engagement with public health changed dramatically. And it was certainly an eye opener to me of just how deep public health penetrates that community, whether that's in our schools, our long-term cares, or in our hockey arenas. And in pandemic mode, public health's a different beast. You know, a lot of the things that we have to do are unilateral. A lot of the recommendations and guidelines we're trying to integrate into our offices and our local environments. And at times it feels awkward, it feels funky. And the PCALS committee really came out of that to help integrate public health COVID findings into local clinical settings. So it's a group of clinicians from public health and from primary care that came together to do that. Now, post-COVID, I think we still feel there's a need to translate some of the priorities and some of the needs of public health into a primary care setting. And the opposite of that, there are needs and concerns of primary care that we would like to bring back to public health. And to have that kind of two-way dialogue, you need a forum, you need a setting, and that's where PCALs come in. So it's the Primary Care Advisory and Liaison Group, and it's a group of representatives from public health and also primary care providers from Niagara who represent a certain catchment area. So mine is part of St. Catharines and Welland, and I take concerns from my catchment. So it might be an issue like a resource issue, like public health, adolescent medicine for mental health resources in Welland. And we would bring that to the group and we would problem solve and say, is there a resource currently available? Is there a resource that could be adapted, or is a new solution required? On the other hand, public health may have a priority that they would like help with. So it might be catching up school vaccines. It could be finding new family doctors for newborn babies. And so we look at some of the practical considerations in our local catchment areas and see how we can work together and address that. I've been on the committee since February, and I can tell you I've learned a lot. In particular, the breadth of programming that's currently available that I probably wasn't as aware of as I should have been, and was certainly underutilizing. And so that's something that I'm able to connect my catchment area with. We have a lot of strong programming here that we could probably use a little bit better. The other thing I've developed are some relationships with the primary care providers in my catchment area. And I knew that the way we worked was pretty diverse, but I didn't realize quite how diverse. We all work in very, very different office and clinic settings. And we have similar problems, but we problem solve them very differently. And it's interesting when we start to share them and come together and share these bigger issues that we're having, we can make a little bit of a difference. I politely call myself mid-career, and the way I like to invest my time, having sat on a number of committees and leadership roles over the past 10 years, I've become a little bit fussier. And I would like to invest my time in things where there's a dialogue you can input and see a direct impact on your community. So I think practicing healthcare and primary care in Niagara at the moment is hard. And the job of PCALS is just to make it that a little bit easier. And if anyone is interested in joining the team, in adding to the discussion, then they should reach out. The committee spot's coming up in 2024, and they would just contact or Google the PCAL website, and all the details are on that. Okay, thank you.
All right, thank you so much, Dr. Greenway. So I'd now like to pass things off to our Medical Officer of Health, Dr. Kazmani, to provide a presentation on local epidemiology of alcohol use and related harms in the Niagara region.
So good afternoon, everybody, and thanks for joining us today here. Really appreciate everybody coming out to see such a big crowd. I think this is our first CME event and open house since the end of the acute phase of the pandemic, even the beginning of the acute phase of the pandemic. We tried to do something, and there always seemed to be something coming up. But it's really nice to be able to come see everybody here. So as Allison noted, my name's Azim. I'm the recently appointed medical officer of health, and I'm going to say that I'm new for as long as I possibly can, because I think it buys me a bit more of a chance to find my way as I go. So I did my training in Kingston, and then I was here for about a year and a half as the associate, and then have recently, I think 4 months ago now, started as the medical officer of health. So this is an interesting topic and one that I think is very important, and we'll see why. And this is an interesting room to be talking to you in, because many decisions are made here. And we obviously know that the wine industry and alcohol are an important part of Niagara's economic foundation, really. But I think it's still important to be true to what we know and what we can tell our patients, especially when they're coming to see us, about the risks associated. And when I speak to our mayors, even if they're from wine producing areas, they appreciate the importance of this and the importance of making sure that our patients are informed so they can make the choice, as well as giving people the opportunity and ensuring that they have that opportunity to make the right choice for them. So I was here earlier doing a budget presentation. I guess they took the clicker away, so I'll turn to Hamza and ask him. Moving on to the next slide. So I think any of us who've worked in clinical medicine have seen the impacts that alcohol can have. Well, according to the World Health Organization, alcohol consumption is one of the top 5 risk factors for death and disease worldwide. You see drinking alcohol is linked to more than 200 different health conditions. There's different types of cancer and at least 7 different types. And remember, I did my initial clinical training in general surgery. We would see this often: breast cancer, colorectal, liver, oral, oropharyngeal, esophageal, and laryngeal. And some of them are cancers you wouldn't wish on anyone, just when you see people go through the treatment associated. And according to the Canadian Cancer Society, drinking less alcohol is among the top 10 behaviors we can take to reduce our risk of cancer. Again, you see a picture of heart there and an alcohol-related cardiomyopathy, but really many types of cardiovascular disease like hypertension, heart failure, high blood pressure, atrial fibrillation, hemorrhagic stroke are linked back. We know the impact on the liver as the processing center for alcohol, as well as the social and societal risks associated with violence. And so there are many harms associated with consumption and excessive consumption of alcohol. So then the costs of alcohol are also significant. And there's a recent report, the Canadian Substance Use Costs and Harms report this year, that was released by the Canadian Centre on Substance Use and Addiction, as well as the Canadian Institute for Substance Use Research from the University of Victoria. And they looked at the economic costs of alcohol in Ontario and Canada, and it's greater than the cost of tobacco, cannabis, and opioids. And we know many of those get a lot of attention. The costs go beyond healthcare. So the report looked at the total costs due to not only healthcare, but as well as lost productivity, criminal justice, and other factors as well. And we see that alcohol tops the chart at $19.7 billion, higher than the others. And then the costs actually outweigh the annual revenue. So there are excise taxes associated, and we see that there's actually an almost $2 billion alcohol deficit, or 34 cents loss for every standard drink sold, when we look at all the costs associated. So Canada's guidance on alcohol and health was released this year, and it replaces the previous low-risk alcohol drinking guidelines. The previous guidelines recommended no more than 15 drinks a week or 3 drinks a day for men, and 10 per week or 2 a day for women, and never over 5, I think, was the guidance. But the more and more we learn, the more, just based on some of this stuff I talked about earlier, it was time for a change, and we saw these new guidelines released. And our speaker, our keynote speaker, Dr. Peter Butt, will be providing further details there. When we look at Niagara, and we see those new guidelines there of the no risk, low risk, moderate risk, and increasingly high risk. And I think that's the important thing to note here. is that we're very used to, and I think St. Catherine's got some extra attention in the media associated with this, but we're very used to a certain number of drinks. But really, it's a gradient. And I think the messaging key behind this is the less you drink, the lower the risk. And it's not as absolute as it may have been portrayed. But when we look into alcohol consumption in Niagara, we see that risk guidance on the big image there. And on the left, on the left are the number of drinks that people report consuming in an average week. And so when we look at our Canadian Community Health Survey, we see that 66% of Niagara adults 19 years or older report 0 to 2 drinks a week. 15.8% report consuming 3 to 6, and 18% report consuming 7 or more. And we see the associated risk there. And when we look at the data comparing Niagara to the rest of Ontario, there's no significant difference. But the worrying thing is that 34% of people report consuming higher than a low risk number every week. And we all also likely know the challenges and limitations of self-reported data as well. Interestingly as well, almost 30% of youth between 12 and 18 have report consuming alcohol in the past year. And again, there's no significant difference between Niagara and Ontario. When we look at binge drinking, and binge drinking is generally consuming, more than 5 drinks in one sitting for men, or more than 4 drinks in one sitting for women. And these are standard drinks. And so oftentimes when people are having a drink, it's much bigger than a standard drink. You see that almost 37.5% of Niagara adults 19 or older reported at least one episode of or one instance of binge drinking in the past year. When we look at the differences between sex, there's no significant difference there. But actually, individuals aged 19 to 44 are much more likely to report drinking 5 or more drinks compared to individuals who are 65 years of age or older. Again, the patterns in Niagara match the rest of Ontario. And according to Canada's the guidance on alcohol and health, binge drinking is actually linked to death from any cause. That includes causes like injuries, violence, heart disease, blood pressure, alcohol use disorder, cancer, etc. And some of those harms as well are related to secondary harms. So they may not be experienced by the person who is drinking, but because of the inhibitory effects may affect others around them. And just quickly, a standard drink is actually only a small can, or 341 cc of beer, cooler cider at about 5%, 5 ounces of wine at 12%, or 1.5 ounces of spirits at 40%. In terms of the burden of health conditions attributed to alcohol in Niagara, there was a recent Public Health Ontario report that broke it down by public health unit and the province. So in Niagara, it's estimated that about 193 deaths and 788 hospitalizations and 7,009 emergency department visits are attributed to alcohol for people age 15 or older in an average year. And that's equal to about 4.2, 2.1, and 3.6% respectively. Some of the conditions include cancer, cardiovascular disease, digestive, endocrine conditions, neuropsychiatric injuries, motor vehicle collisions. So quite a significant burden on our local healthcare system as well. And just quickly, looking at alcohol and COVID-19, I think the pandemic and the associated measures needed to protect our population and their healthcare system did have other effects as well. And when we look at alcohol consumption, it's very interesting because there's a mixed pattern that appears. We look at the beginning of the pandemic and alcohol sales actually increased in Canada initially. And then Canadians reported consuming more because they might have been bored, they might have been experiencing some stress, some change in their routine, They might have found themselves at home more often with nothing to do. And as well, we saw some loosening of alcohol restrictions to accommodate those stay-at-home orders, but also to help the economy as restaurants who may serve alcohol would now be able to sell, for example, alcohol as part of takeout. We've also seen a gradual trend away from known measures that are very effective, like accessibility, for example. And the more we see alcohol accessible to the average or to people, let's say in the grocery store, which we now see it, whereas we didn't before, consumption tends to go up. Excise taxes are another area where we see a lot of a strong correlation between consumption and cost. So in 2022, among Niagara adults age 18 or older, about 14% reported that their alcohol consumption has decreased since the pandemic began, and actually 14% reported that their alcohol consumption increased since the pandemic began, and that was in 2022. So certainly a mixed picture, and I think we see things go both ways, where the social patterns may have changed, but also information like that's available from the new guidelines may help people make different decisions as well. So that's a little quick snapshot of what we're seeing in Niagara and some of the contributing factors, and I'll turn it back to Alison to introduce her.
All right, thank you, Dr. Kazmani. So before we move to our keynote speaker, we're actually going to do a little bit of a survey. So we're going to be using a survey system called Mentimeter. So for those of you who aren't familiar with it, if you have a cell phone or a personal laptop or some kind of electronic device, if you wanted to participate and go to menti.com, once you get to that website, you'll be able to enter a code. So this will allow for participation both for those of us in the room as well as those attending virtually as well. So we just have a few questions that we thought we would pull those of you who are attending, just to kind of see what your experience has been with some of your clinical interactions with patients. So the first one is, in your role, how often do you engage in conversations about alcohol use with patients? So often, sometimes, rarely, or never. Oh, it's just at the top of the screen. Yes. Yep, take your time. So the code is 16896710. It's just at the top of the slide. Just give it a moment because I know you're just starting this up and getting it loaded on your phones. Right, so it looks like the majority often or sometimes have conversations with patients. I know there are some different roles of attendees, so there might be some reasoning behind some of these answers, but it does look like the majority are often or sometimes having those conversations. So we'll click to the next one. So what is your comfort level engaging in conversations about alcohol use with patients? So very comfortable, comfortable, somewhat comfortable, or not comfortable. Great. Yeah, it looks like there's definitely some level of comfort, which is great to hear. So the next question is, during your conversations with patients, would you say individuals are aware of the health risks of drinking? So definitely somewhat aware, slightly aware, not at all, or not applicable if you don't have those conversations. All right, so it looks like most are maybe a little bit aware. Seems to be pretty consistent with what we know when it comes to the harms related to alcohol. Okay, so we'll go to the last one. So how familiar are you with Canada's guidance on alcohol and health? So this is our new guidance released this year. Okay, great. So it looks like most of you are at least a little bit familiar, and hopefully you'll learn something this evening from our keynote speaker. So thank you all for participating in the Mentimeter. So we are actually going to flip to our keynote speaker. So I would like to introduce to you our keynote speaker for the night, Dr. Peter Butt. Dr. Peter Butt is a certificate and fellow of the College of Family Physicians of Canada with special competency in addiction medicine. He is a clinical associate professor in the Department of Family Medicine at the University of Saskatchewan and served as a consultant in addiction medicine in the Saskatchewan Health Authority for 24 years. In addition to teaching and research, he's chaired the original development of Canada's low-risk drinking guidelines from 2011. He's co-chaired the Canadian Guidelines on Alcohol Use Disorder among older adults from 2019, and then more recently has co-chaired the 2023 Canadian Guidance on Alcohol and Health with the Canadian Centre on Substance Use and Addiction. So I will pass it over to you, Dr. Butt.
Great. Well, thank you very, very much for the opportunity to speak with you today, and the introductory comments were much appreciated. First slide, please, if we could slip to the deck. Wonderful. Thank you very much. Okay, let's continue on then. Next slide. Yes, next slide. So in terms of disclosures, I really have no industry or other specific conflicts of interest. Next slide. For the purpose of the study, all 23 of the content experts representing 16 organizations nationally underwent Guideline International Network Disclosure of Interests and Management of Conflicts. And this was overseen by the Public Health Agency of Canada. So we were able to do a very thorough COI process. Next slide. What I'd like to cover here is a bit on the methodology and evidence behind the changes, because as you heard in the introduction, there's quite a dramatic shift from 2011 to 2023. I think it's important too to learn how alcohol use contributes to health risks for various diseases, including cancer and heart diseases, Dr. Kasmani mentioned in the introduction. And also, more importantly, perhaps I'd like to outline the clinical implications of the guidance, including opportunities during various patient interactions for discussing alcohol consumption and related health risks, far beyond alcohol use disorder alone. Next slide. So how did we get to where we are now with regards to the guidance? Next slide. We started with PECO as opposed to PICO questions, PECO being exposure rather than intervention, with regards to long-term risks, short-term risks, and women who are pregnant or breastfeeding. Now, you'll notice here that we were looking at risks and benefits simply because we had to be open to the possibility of benefits from low levels of alcohol consumption. Next slide. We only had 2 years. Fortunately, Australia had gone through a 5-year process using very credible approaches to the literature review. So their data went back from 2000 to 2017. We reviewed and assessed their systematic searches on the impact of alcohol use. We then added in approximately 6,000 more systematic reviews that covered 2017 to 2021, which then gave us 239 systematic reviews that were screened for full text eligibility. We used Agree2, AmStar2 tools as well as GRADE in this process. Next slide. Now, what we then landed on was 16 systematic reviews of the highest quality. Could you click again, please? And then we use mathematical modeling. Now, there were a couple of things that were very important in terms of methodology compared to 2011. We used years of life lost because this captures both morbidity and mortality much better. We also used, as a comparison group, lifetime abstainers. Now, in the past, historically, people have tended to use current abstainers for their comparison. The problem with current abstainers is that it includes sick quitters, people who are no longer drinking because of ill health. So it really doesn't give us a clear sight line, if you will, between the amount of alcohol consumed, the dose, if you will, and the impact on health over time with increasing amounts consumed. And what we wanted from the literature review, of course, were the relative risks. Click again, please. Now, in addition to the relative risks, we wanted to include absolute risks with regards to a threshold of 1 in 1,000, click again, and 1 in 100. Now, those thresholds are important because as many of you know in this audience, in terms of acceptable risk for involuntary exposure, that would be 1 to 1,000,000 with regards to air or water. With regards to voluntary activities, typically the epidemiological standard would be 1 in 1,000 with regards to premature death or disability. Historically, alcohol has been looked upon through a lens that's skewed towards culture, towards the social impact and the economy. And that's why historically people have used a 1 in 100 risk level for defining low risk. It doesn't relate to the actual impact on health, however. So it really has given alcohol a tenfold increase with regards to how we present low risk when we compare it to other voluntary activity. We also looked at thresholds with regards to males and females. Click again. So the levels that we ended up with in this exercise were 2 standard drinks per week at that absolute risk level of 1 in 1,000, click again, and 6 standard drinks per week for the absolute risk threshold of 1 in 100. So this presented a bit of a challenge. And how do we present this to the Canadian public? And that's why we landed on the guidance that we did. But I think we should comment on sex as well, if you could click it again. What we found at those low levels of consumption, up to 6 standard drinks per week, was no significant difference with regards to males or females, despite differences in the physiological metabolism and distribution of alcohol. However, once you get into the 7+ standard drinks per week, you see an increasing level of risk for cumulative harms amongst women, drink for drink, compared to men. There's also a gender approach to this that I'm going to comment on later. Next slide. What we also found in our focus groups is that people wanted us to focus on the facts rather than strict rules or patronizing messages. They didn't want us to tell them what to do. They wanted to be informed about the guidelines, why they're there. They wanted us to keep the messages short and simple and clear and give people actionable information so that we could meet them where they're at. They could then take this information with some actionable recommendations to consider when they're reviewing and assessing and reflecting on their alcohol consumption. Next slide. So what were the recommendations? Number 1, next slide. It was very simple. Before I get into that, we shifted from Canada's low-risk alcohol drinking guidelines to Canada's guidance on alcohol and health because we felt it best to adopt a risk zone approach, similar to what many people were exposed to during the pandemic. Next slide. This is the primary recommendation. To reduce the risk of harm from alcohol, it is recommended for people living in Canada to consider reducing their alcohol use. Period, full stop. That was it. We did not recommend a specific number, but rather we went to the risk zone way of presenting the information to the Canadian public. Now, what you heard in the media many times over was that we were recommending no more than 2 standard drinks per week. And people went quite apoplectic over this, but it did attract a lot of attention, which was interesting. But it really does require correction through the knowledge mobilization phase. Next slide. This is really the crux of it, because when we look at what's low risk up to that 1 in 1,000 level, 1 to 2 standard drinks would define that zone. Risk increases with the amount consumed. There's absolutely no safe level of alcohol consumption. So if people don't want to have any risk through alcohol exposure, they should not drink. It should be 0. However, 1 to 2 standard drinks would give them a low risk level of exposure, going up to that 1 in 1,000 level. 3 to 6 standard drinks increases that risk to a moderate level with increasing risk of 7 different types of cancer, which has been commented on by Dr. Kosmani, and I'll go into in a little bit more detail as well. That 3 to 6 risk zone we defined as moderate, which takes us to the historical level of low risk of 1 in 100. And then at 7+ standard drinks per week, you're seeing an increased risk of not only heart disease, but liver disease, cardiovascular disease, and so on. Next slide. In order to understand this, of course, and we've heard about it already this evening, is that people need to understand what a standard drink is. 13.45 grams of ethanol mean absolutely nothing to the average consumer. And the percent alcohol by volume that is labeled on beverage alcohol by legislation, again, means absolutely nothing to the average consumers. They relate to it in terms of the container, in terms of the size, but the percent of alcohol really does make a big difference. And we see this with regards to tall boy containers of beer. Not only is the concentration of alcohol greater, but so also is the volume. And then you have wine that might be anywhere from 12 to 14+% of alcohol. So the number of standard drinks in the container is really important for consumers to know and to understand, because they can't manage what they can't measure. Next slide. The second recommendation has to do with the acute effects of alcohol. And that's consuming more than 2 drinks in one occasion is associated with an increase of risk of harms to both self and others, including injuries and violence. So this is where avoiding acute inebriation is important to reduce those acute harms. Next slide. The third recommendation with regards to reproductive health was very straightforward, nothing new. When pregnant or trying to get pregnant or when breastfeeding, it's best to not drink. Next slide. We also commissioned reports because not everything that people wanted us to investigate could be found in the literature or reflected in relative risk graphing. So we did a systematic review or an update on the effect of alcohol consumption on the development of depression, anxiety, and suicidal ideation, because people were interested in the impact of alcohol on mental health. Sex, gender, and alcohol was also an important consideration, and this led to a second commission report. We wanted to look at the association between alcohol use, aggression, and violence. And so this was commissioned, as well as the risk of alcohol use per occasion, which became one of the specific recommendations. Next slide. So with regards to alcohol and mental health, this Cochrane review was challenged by a lack of evidence. None really met the evidence threshold for inclusion in terms of the few systematic reviews that we found. The challenges related to problems with thresholds, problems with definitions for alcohol quantity and frequency, failure to report odds ratios with standard errors or confidence intervals that's really required for data pooling. The results were difficult to interpret, And it misclassified abstainers in terms of current abstainers as opposed to lifelong. What we know is that the relationship between alcohol and mental health is bidirectional. And we need to be able to tease this out in terms of, did an individual have an established mental illness prior to the onset of alcohol use? Or on the other hand, did it evolve whilst they were drinking? And what is this? How do we tease out this bidirectional nature of it so we can understand the impact of alcohol in terms of exacerbating a mental illness or bringing it on, as opposed to a mental illness leading to increased levels of alcohol consumption in a form of chemical coping? Next slide. Sex and gender is really important when we're starting to look at the knowledge mobilization around this and some of the nuancing in the messaging. Above the upper limit of the moderate risk zone, as I mentioned, the cumulative risk increases more steeply, more rapidly for women than for men, because drink for drink, their blood alcohol level stays higher longer. And then, of course, we get into injuries and violence. Next slide. With regards to violence and aggression, what we found in the commission review is that a lot of this is related to acute intoxication or heavy alcohol use. And what we saw is that increased consumption led to predominantly male-perpetrated intimate partner violence, male-perpetrated sexual violence, and male-perpetrated general violence. And although the associated victim drinking, typically female, did increase risk, it does not render them responsible for the violence. So we needed to have a very gender-based approach to messaging with regards to alcohol use, violence, and aggression. This is both sex-based, if we think about the combination of alcohol with testosterone, but it's also gender-based when we think about toxic masculinity tropes and the notion that drinking alcohol, becoming intoxicated, gives people permission, men in particular, permission to perpetrate violence on others. Next slide. So what we have here, I'm going to have to stop my video because I see my head flickering there. There's a problem with the connection. What we see here is fundamentally the consumer's right to know. They have a right to know this information. We also have come out with a very simple communication strategy that less is better. Less consumption means less risk with regards to carcinogenesis, cardiovascular disease, and in terms of acute intoxication, injuries, and violence. But the consumer has a right to know, and I think it's important that they're presented with this information in a very neutral, non-judgmental way to prompt reflection and guide them, if they will, in terms of reduction, if that's what they choose to do. Next slide. This involves cost-effective public policy, however, because we know that public policy impacts availability and use. So this is where standard drink labeling is very important. Again, people can't manage what they can't measure. People have a right to know with regards to alcohol as a group 1 carcinogen and its impact on cardiovascular disease. And in many jurisdictions, they also include guidance on alcohol and health labeling. There's approximately 40 plus jurisdictions internationally that require some form of this type of labeling. Next slide. So what about the knowledge transfer in the medical or clinical implications? Next slide. Well, we know that there needs to be further dissemination, exchanges and expert advice is required, training and tools, and truly collaborative efforts in order to get this information out to different populations in a more appropriate ways. Next slide. The context of alcohol consumption in Canada is important because if you include the abstainers at 22% of the population on average, across the country, Another approximately 22% or less than 3 standard drinks per week in that low risk zone, another 17% in that 3 to 6. And so in the low to moderate risk zone across Canada, we have 60+% of the population that are already at that low to moderate level. However, 40% of the population approximately are in that increasingly high risk zone. And over 80% of the alcohol consumed is consumed at these higher levels. So these are the people that actually would benefit the most from some of the knowledge mobilization. Next slide. If we look at this in the context of drinkers now, we eliminate those that are abstainers already. Again, you see 50% approximately low to moderate risk amongst people who drink, and another 51%, if you will, in that higher risk zone. So a split. What we need to do, I think, is to denormalize high level alcohol consumption. It really is no more the norm in Canada. If we include abstainers, it's even less normalized compared to low to moderate use or abstinence. So we need to change some of the views that people have on alcohol consumption in Canada. Next slide. The clinical implications involve a number of different conditions. Now, there's over 200 that are ICD coded. We looked at 40 and actually found good evidence for 16 of the World Health Organization conditions that are attributable to alcohol. So with regards to females, if you look at the chart for the average alcohol intake in grams per day, 13.45 or 1 standard drink per day would be between 10 and 15. So if you draw a vertical line there, you'll see the impact of 1 standard drink per day with regards to increasing risk of hypertension, atrial fibrillation, and flutter, intracerebral bleeds, as well as subarachnoid hemorrhages. With regards to what has previously been the focus and thought to be the cardioprotective effects of alcohol on the heart, with regards to ischemic heart disease and ischemic stroke, with our change in methodology, you see this coming down to a level that isn't statistically significant. It doesn't exceed the confidence intervals. So at best, it's considered neutral with regards to a cardioprotective effect. Overall, the impact on the heart is not protective. And I'll comment on this a little bit further. With regards to liver cirrhosis, increasing consumption, increasing risk for women. And then you see the impact, again, specifically with regards to levels of consumption relative to breast cancer, colorectal, liver, esophageal, oropharyngeal, and laryngeal cancer. So increasing consumption, increasing risk. Next slide. For males, it's much the same. You see a neutral cardioprotective effect with increasing risk with the amount consumed. Perhaps not as profound with regards to liver cirrhosis compared to females, but certainly present. And again, significant risk in terms of the 6 cancers that impact males with the elimination of breast. Next slide. With regards to cancer causation, let's go back a slide, please. So the clinical implication is that we have many opportunities, primarily in primary health care, to have conversations with people with regards to alcohol consumption. When they're coming in to check their high blood pressure, if they have cardiovascular disease, if there's any concerns with liver health or concerns with regards to cancer risk, these open up the opportunity to ask about quality and frequency of alcohol consumption, to inquire into their knowledge of the risks and harms with regards to their level of consumption, and provide them with more information. It can be done in a very neutral, pro-health way. This doesn't need to call into question the stigma of inquiring with regards to an alcohol use disorder, although it's important that we do that as well. but it can lead to a much more neutral, non-stigmatizing conversation with regards to alcohol and health. Next slide. With regards to the criteria for cancer causation, a group 1 carcinogen needs to have evidence that demonstrates the cellular impact of the mechanism. Secondly, an animal model that reproduces the mechanism. And thirdly, the epidemiological data that establishes the association in the human population. Alcohol meets all 3 criteria for the 7 cancers that we've referenced. Next slide. When we look at those cancers, the percentage that's causally associated with alcohol for each of them is highest in the proximal GI tract, where there's a direct inflammatory effect on the mucosa, in the mouth, the oropharynx, the esophagus. And then through the blood, we see the impact on the liver, perhaps inhaled alcohol in terms of the larynx. Colorectal would be both direct and blood-borne, and then, of course, breast and liver. But if you were to look at the number of people impacted because of the prevalence of breast and colorectal cancer, you see many more people impacted by alcohol use through breast and colorectal cancer than you do with cancers of the proximal GI tract. So this is a significant level of impact in the proximal GI tract, significant number of people impacted in terms of colorectal and breast. Next slide. With regards to alcohol and heart health, it's important for cardiologists and primary care providers to realize that the World Heart Federation came out with a policy brief in 2021 that really debunked alcohol is good for one's heart health. And certainly said that risks due to alcohol consumption increase for all major cardiovascular diseases, including hypertensive heart disease, cardiomyopathy, atrial fibrillation and flutter, and stroke. Next slide. When it comes to using this guidance in screening and brief intervention, I think it's important at the primary healthcare level that we expand it out from SBIRT to CIPR to the third. So it's screening, it's intervention, there's the use of pharmacotherapy as indicated, referral to community resources, reassessment like any chronic disease, and recovery support. This is if people meet criteria for an alcohol use disorder. So quantity and frequency is part of that. Using audit or a similar sort of screening tool would be helpful then, or some people might simply want to use a narrative approach, thinking about the DSM-5 criteria for an alcohol use disorder. This guidance can be helpful in reinforcing primary prevention or secondary prevention in terms of people that might be at elevated levels of consumption or perhaps a low risk of an alcohol use disorder. Certainly, informing people, challenging them to reduce the amount helps to smoke out, if you will, or identify people that actually have lost control. They're underreporting, they're having more problems than they're reporting. And by going through a challenge, if you will, or a trial, would be more neutral language with regards to a lower level of consumption, people can perhaps appreciate that it has become more compulsive and they have indeed lost control. Next slide. With regards to individualizing risk, we need to prompt reflection on the risk, not only of alcohol alone to people, but also what's their past history of conditions that are causally associated with alcohol, or indeed, what is their family history of conditions that are causally associated, so that we can help them to identify their individual risk, perhaps at a higher level than their population risk. Next slide. And presenting people with this information in terms of the risk zone, hopefully is going to help them to situate their drinking. Are they indeed in an elevated risk zone at 7+ standard drinks per week? Are they interested in reducing their week to 3 to 6 standard drinks per week in the moderate risk zone? Or are they thinking of perhaps going to a low risk zone of 1 to 2 standard drinks or lower? This is something that people reflect on, and frequently when they start to engage in this sort of conversation, their goals tend to decrease over time. Next slide. So a triaged approach to goal setting can be useful. We need to keep in mind that individual risk comfort is variable and not necessarily grounded in an actual personal risk. So in general, the message is reduce, less is better, with a potential goal of 6 standard drinks per week or less. If they have an increased personal risk of an alcohol attributable condition, then we should recommend 2 standard drinks per week or less. If there's an actual presence of an alcohol attributable condition or one that would exacerbate that condition, the advisement would be to consider 0. Now, you might have somebody with hypertension on pharmacotherapy that would benefit from going to 0, but the risk perception is such that maybe they'll just go to a moderate risk level of 3 to 6 standard drinks per week. Somebody, however, who perhaps is concerned about breast cancer but doesn't have a family or personal history may actually want to go down to the lower risk level of 2 standard drinks per week, because again, their perception and concern with regards to risk varies depending upon the condition. And we need to work with people on this and respect the decision-making process, recognizing that that risk comfort is highly variable depending upon the condition. Next slide. So of course, we use a stage of change approach and motivational interviewing as part of our response to people. We want to start where they're at. Next slide. And this is where understanding why people drink is helpful. There's personal effect motives as well as social effect motives. Many people combine the two, but on the more personal driven ones, people drink for enjoyment, to alter mood, to avoid boredom, to escape problems, or quite frankly, to get drunk. With regards to social effect motivators, people drink to socialize, to celebrate special events. Alcohol is used to mark the end of a work day, the end of a work week, to celebrate or to mark the passing, to celebrate birth or marriage, or to mark the passing of somebody in terms of their death. It's also used to increase power, which is an interesting one to unpack with regards to power lunches or competitive approaches to drinking alcohol. And there's also the social ritual that's often attached. So how we help people to make changes depends in part on why they drink and what motivates them. This isn't about removing all fun and joy out of life. It's helping them to look at socializing and perhaps emphasizing the company they're keeping rather than the chemical that they're consuming. And so also with regards to looking at other motivators. Next slide. We can also talk about the benefits of alcohol reduction. It's not, again, about taking away fun or pleasure, but enhancing health. If they decrease less, they decrease their calories and lose weight. They can improve sleep and have more energy. Decreased alcohol consumption improves cognition and memory. It improves mood. It also decreases blood pressure, blood sugar, triglycerides, liver fat, and can improve one's sex life. In addition, there's improved immune function. There's decreased cancer risk, decreased risk of accidents and injuries if one decreases the amount that they're consuming acutely, improved relationships, less conflict, improved communication, and also financial savings. So there's a host of benefits that we can present to people in a more positive way with regards to this conversation on alcohol and health. Next slide. Harm reductions are important, strategies are important. We need to encourage people to keep track of how many standard drinks they have per week, which is a bit of a challenge. Encourage them to decide on a weekly drinking target and stick to that limit if they can. If they can't, why not? Let's explore that. It's important to eat before and whilst one's drinking to slow the consumption or the absorption of alcohol. People should drink with beverages with a lower percentage of alcohol. And the industry has responded to this in many ways, and that's very helpful. People should drink slowly in small sips. Shooters are not recommended, of course. Always have water on hand. And indeed, hydration helps to decrease the level of alcohol that people consume, as well as their experience of a hangover. People should alternate between alcohol and non-alcoholic beverages, and also explore alcohol-free products. As I mentioned, the industry is responding to this in many different ways. Next slide.
Thank you all for attending as well, and Dr. Butt for being our keynote tonight. We really appreciate you making the time to attend, and to all of you for being here. So we are going to wrap things up. The session has been recorded. We are going to edit out the question and answer period, so that won't be included in the recording, but we'll make sure that that gets shared afterwards. There's also a couple slides that we've included for some local resources as well. So from CASIN as well as Niagara Health as well. We do have a couple slides in there for those of you who were looking to get a little bit more of that information if you weren't able to connect with them at the open house prior to the event. But again, thank you all for being here tonight with us. There will be an evaluation that will be sent out afterwards, and you'll subsequently receive your certificate for attending as well. So again, thank you all for being here tonight.